everyone, and welcome to another episode of MedSynapse podcast series, where we bring clinical insights to the forefront of healthcare conversations. And today's episode dives deep into a high stakes and often time sensitive area of intensive care, which is toxicology in the ICU. From antidotes to dialysis to rapid decision making, we'll explore how critical care teams handle poison patients and what it actually takes to make life-saving decisions under pressure. Joining us is someone who knows this space inside out, Dr. Balaji Rajaram, a seasoned critical care specialist with over 8 years of experience managing critically ill patients across multidisciplinary ICUs. He holds an MD in anesthesiology, a DM in critical care medicine, and the prestigious European diploma in intensive care. So, Doctor is also the part of the critical care consultant group and is deeply respected for his calm leadership, evidence-based approach, and nuanced handling of complex ICU cases. So, Dr. Balaji, we are so excited to have you and welcome to the show.
Thank you. Thank you, Ms. Hetty. Thank you for your kind introduction. Yeah, thanks for having me in this wonderful session. Thank you, MedSynapse, for having me in this session.
So, Doctor, could you start by sharing your journey into critical care and what sparked your interest in toxicology within the ICU settings? And also, could you discuss some of the most commonly encountered toxins in ICU settings?
Okay, it's an interesting question. See, I would like to start my journey into the ICU as well as toxicology. I would like to start right from my UG days. I have completed my undergraduate education at Tanjore Medical College, where I have exposed to a broad spectrum of clinical cases, which includes toxicological cases as well. With particular emphasis to toxicology in our region, pesticide poisoning, especially the organophosphorus poisoning, is highly prevalent. I'm not sure whether you have heard our region, that is the Tanjore region, has been popularly referred to as Kaveri Delta region because it is a pretty fertile area because of the river Kaveri. So the agriculture is a predominant occupation. So since agriculture being a predominant occupation, the access to the pesticides and insecticide is quite high. So we do have a lot of exposure for a pesticide and insecticide poisoning. So that provided me with a first-hand experience in recognizing and managing such cases early in my medical curriculum training. Being an intern, I will be a first responder, but I may not be a team leader in managing such patients. Of course, the junior resident in medicine, that is a medicine PG, and the consultant in medicine will be the team leader in managing such a complex toxicological patients. But being an internship, while doing my internship, being an intern, I'll be a first responder in managing such patients. So I do have a lot of exposure while managing such pesticide poisoning, toxicological patients during my internship stays. During my postgraduate training in anesthesiology at Madras Medical College, I further had an opportunity to deepen my exposure in toxicology. Madras Medical College as an institute is a regional toxicology referral center. It has a dedicated 12-bedded ICU exclusively for toxicological patients, since it is a regional toxicology referral center. This unique setup allowed me to gain some clinical experience in managing critically ill patients in various complex poisoning because it is a referral center. For the first time, I got exposed to a renal replacement therapy there. At that point of time, the continuous renal replacement therapy is not available, but they do have a plasma exchange. For the first time in my life, I got exposed to plasma exchange there. And ventilatory support and advanced organ support is there. During my exposure and during my residency of anesthesiology in Madras Medical College, the most common toxin we have encountered is rodenticide, again pesticide, and all the other toxins like caustic alkali, acid ingestion, toilet cleaners. These are some of the most common poisoning which we have encountered during my residency days in anesthesia. Following my postgraduate training in anesthesiology at Madras Medical College, I went on to pursue my fellowship in critical care medicine at Christian Medical College, Vellore. Again, Christian Medical College, Vellore is a referral and tertiary care center. It is again a hub for a referral center for the toxicological patients. And the faculty at Christian Medical College, Vellore have done some virginal research pertaining to organophosphorus poisoning. And Christian Medical College, Vellore per se is a referral center for numerous plant-based alkaloid poisoning. Okay, So again, I do have a first-hand experience in managing those complex clinical cases. Then I pursued my DM Critical Care Medicine at the All India Institute of Medical Sciences, the best medical institute in the country. And AIMS was the National Poison Information Center. And I had the opportunity to further expand my clinical and academic competencies in this domain. So if you see, being an intern and being a first responder during my UG days, this progressive stages of training, I tend to develop the strong academic interest and clinical proficiency over a period of time. And following throughout my training period after this, I have joined Apollo Chennai as a consultant. Here we do have all possible organ support system currently state of the art functioning. We do have a dedicated ECMO unit. We do have a CRRT. We do have in case if there is a paraquat poisoning, we do have a dedicated filter system for the same. So this per se, now we have managed a complex beta blocker and calcium channel blockering with extracorporeal circulation. These cumulative experiences right from undergraduate days to and as I am working now in a good corporate tertiary care setup has given me a foundation in both handling medical toxicology cases.
I think that's a wonderful journey as whole, and thank you for highlighting your journey, Doctor.
Yeah, I would like to thank God Almighty for this opportunity. That's all. Yeah, it's not my, I can't take the credit all alone.
Doctor, now moving on, how do you balance the urgency of intervention with the need of diagnostic clarity in suspected poisoning cases in the ICU? I believe that would be very crucial.
So, as far as the management of the toxicological patient is concerned, one, it is a teamwork. There is no me in toxicology. One should understand it's a teamwork. And what does a team comprises of? Sometimes the team extends beyond the team inside that one particular hospital. For example, I'm working in a primary health center. I'm encountering a patient with a complex poisoning. So, in case if I'm referring that patient, then I am a part of the referral system. So, I'm a team member. I should alert the emergency medical services, that is the ambulance person. So, he's a second member of the team. Third, where to which ER I am referring, he's a third member of the team. And to which ICU the patient is going, he's a fourth member of the team. So likewise, the team starts right from the first point of contact through the through which ambulance the patient is getting referred to the destination place. Okay, so it is a teamwork. And fourth, the team not only comprises of just ER physician or the ICU consultant, it also includes specialists from other areas like nephrology, specialists from other areas like ECMO team, specialists from other areas like psychiatry, because deliberate self-harm, that is ingestion, deliberate self-harm or ingestion, there will be a particular psychological stress. You can't just treat the patient and say, yes, you can go home. You have to treat the underlying stress as well. So the team comprises of, you have to treat the underlying cause as well. And sometimes, in case a patient comes to your ER, sick of the sickest cases, for example, OP poisoning, which is one of the most common cause of pesticide poisoning in South Indian settings is concerned. To attend a OP poisoning in South Indian settings, you need at least 2 to 3 members at least during the initial phase is concerned. So, first, to answer your question regarding the balance, the urgency of intervention, you have to understand that managing a toxicological patient needs a teamwork first. Second thing, there is a traditional teaching in medicine that the history taking should be very detailed. You should draw a family tree and all those things. Here, we should follow the history taking methodology as they describe in trauma. So it should be a targeted history taking because there is a medical emergency right in front of you. So always get the history from the first responder because always we tend to get history from the first responder. He will go somewhere, probably to sign some forms, probably to pay some bills. The first responder will hand over to some other relative will hand over to the third relative. Always catch hold of the first responder because as someone is getting over and the other person is getting hand over, the bridge in communication, the lack of communication will get there will be so many gaps in communication which gets added upon. Always get your history from the first responder. One. Two, cut short the history and take the ample kind of history. That is allergies, medication, past medical history, last medical need, event or environment. Collect prescription of the patient, collect prescription of the relatives, empty containers, empty strips around the patient. In a house, if one person consumes poisoning, doesn't mean that he has to consume his own prescription. He can consume prescription from his mother, his father, his own husband, or his spouse, whatever it is. And doesn't mean that you can leave the history taking, drop it there itself. Once you stabilize the patient, come back to your history taking and complete from where you have left. So to start with, before stabilize the patient, it should be a targeted history taking, always from the first responder. So this is the second thing which I wanted to highlight. Don't forget the comorbidities, because some of the comorbidities may change your management. For example, in case if you want to decontaminate a patient, for example, you want to do a gastric lavage in a patient who have consumed some polydrug overdose. If the same patient has underwent a upper GI surgery, then becomes a absolute or relative contraindication. So significant medical history and comorbidities you should emphasize on. Third one comes the as usual stabilization. So this emphasizes the teamwork. For example, if one person is concentrating on getting the airway, breathing, circulation, and disability stabilized, the other person will get a targeted history taking parallel. Okay, so the always the first responder should take care of the airway, breathing, circulation, disability, and exposure. As long as in poisoning patient is concerned, the disability should include a rapid neurological assessment, point of care, blood glucose, finger prick, blood glucose, papillary reaction, and the exposure you should look for any needle marks, any rashes, any hesitation cuts, which may signify that there is a previous deliberate self-harm attempts as well. For example, in toxicological emergencies like organophosphorus compounds, your airway, breathing, circulation, disability, apart from intubating the patient or giving oxygen, it may include administration of atropine as well, because giving atropine may clear the airway secretions. Giving atropine may improve your neuromuscular power, which may improve your breathing as well. Giving atropine by improving the heart rate may improve the circulation as well. So in toxicology, always the ABCD approach comes first. So it is a teamwork. One person should concentrate on ABCDE, and the other person of the team should go and elicit a targeted history taking. Fourth one is a toxin-drome based approach. What is a toxin-drome based approach? Sometimes, because when a person is attempting a deliberate self-harm, yes, some of them, there can be a letter, there can be a text, there can be a sharing a message in a social media, but that is not always the case. There will be if they want to do it pretty discreetly. So you may not always have a clue that what this patient has consumed. At the end of the day, you might have a patient who no one knows what happened to him. He is lying unconsciously in front of you. So to know what he has consumed, you can't wait for the lab reports to come and say that, okay, this person has consumed this, come, let's start treating this patient with this. So you should know how to approach that patient. So how will you approach such patients? So it is a toxin-drome based approach. The common example of one is a cholinergic syndrome. So cholinergic syndrome is nothing but a common example is organophosphorus poisoning. Diarrhea, urination, meiosis, low heart rate, that is bradycardia, recurrent vomiting, emesis, lacrimation, salivation. If patient has a constellation of these symptoms, probably he has consumed some compound like organophosphorus. So the treatment is going to be atropine. One more example is anticholinergic syndrome. For example, the common mnemonic goes like this: hot as a hair, dry as a bone, red as a beet, blind as a bat, mad as a hater. If patient is manifesting constellation of these symptoms, probably he has consumed some anticholinergic substances. The treatment is benzodiazepines. In some cases, it is physostic. Okay. Opioid tox syndrome. Pinpoint people's low respiratory rate, decreased consciousness, high CO2. If the patient is having constellation of these signs and symptoms, probably we are dealing with a opioid tox syndrome. So if there is no history, probably the toxin-based approach is something which may help us to clinch the diagnosis. Then, so you have finished history, you have stabilized the patient A, B, C, D, E, targeted history, clinical examination, then comes the investigation. What are the investigations? The first thing is point of care, which is immediately available in your ER and ICU, which is your acid base, ABG analysis, electrolytes, liver function test, renal function test, etc. Other things are specific drug levels. Drug levels may not be available for all the toxins, but certain toxins like paracetamol levels, alcohols, salicylate, digoxins, a few examples like this may have drug levels. Some of the toxins, for example, tricyclic antidepressants, serum digoxins, doing a serial ECG may help in cleansing the diagnosis. So I think to comprehensively answer your question, for example, you want to know the balance, the urgency. So in case of urgency, one always loses the clarity. To avoid losing the clarity, always go in a structured way. Always remember, one, it is a teamwork. So always call for help. One. Two, A, B, C, D, E. Stabilization of airway breathing circulation is a priority. When one member of the team is doing this, the other member of the team should ask targeted history. Then go by the toxin room based approach. Then do a specific investigations. Start with what are the point of care tests available, like ABG and capillary blood glucose. Then do the basic labs. If needed, do the special tests like serum, drug levels. And don't forget to do ECG, which may help to clinch the diagnosis in certain toxicology, certain toxin rooms.
I think Doctor, that is good description, and I think that clinical judgment is what really needs to
Yeah.
define critical care also. So now, Doctor, can you walk us through a memorable or complex ICU case where rapid toxicology intervention made a significant difference in outcome?
See, I could remember n number of patients where
Mm.
I can have a memorable outcome. Since you have asked for one patient, the what could immediately flash in my memory is this one particular patient.
Mm.
Patient came to us after consuming significant number of beta blocker and calcium channel blocker poisoning. At that point of time, I was transiently doing a locum practice in a hospital where they don't have a facility for a transvenous spacing or there is no facility for extracorporeal circulation as well. So day one patient was requiring four vasoactive agents. We tried to manage this patient. Day two, patient was getting sicker and sicker, started having toe discoloration. Patient was on high HIET therapy, high insulin euglycemic therapy as well. We are giving continuous calcium. Yes, eventually she got better, got discharged, but she developed pancreatitis because of hypoperfusion and high calcium, and she required one or two hospital-acquired infection. Fast forwarded after 6 years, when I came back to Apollo as a consultant, same level of beta blocker and calcium channel blocker poisoning, use of ECMO, patient improved dramatically after 2 years. So basically, this indicates that the timely intervention, the critical role of good intensive care, and there is a potential of full recovery is there when the importance of timely referral, use of transvenous spacing, and VA ECMO, veno-arterial ECMO, if those advanced medical care is available, then the recovery is dramatic. I would like to emphasize on this particular patient because the what happened next immediately after the management was kind of interesting. Patient came to us after the consumption of polypharmacy. The patient had consumed close to 50 tablets of atypical antipsychotics, 30 tablets of benzodiazepine, and some 50 tablets of triaxipinidine. As expected, we didn't. Patient was already intubated in our referral hospital. We didn't give any reversal. Ventilated for a couple of days, extubated. And the interesting clinical problem is what happened next. Patient had a recurrent episodes of postural hypotension. So then, when we went back to our drawing board and see what exactly happened is triaxipinidine, basically with its anticholinergic properties, impairing the autonomic tone, and the atypical antipsychotics with the anti-alpha blockade, contributing to this vasodilatation and orthostatic intolerance. Subsequently managed with IV fluids, oral midodrine, and absolute bed rest. I just want to say this is interesting and want to convey this to the audience because we always concentrate that the life-threatening toxin we always miss the minor pharmacological properties of the same medications. Yes, by consuming the overdose of benzodiazepines or atypical antipsychotics, sedation, yes, respiratory depression, yes. But these kind of minor side effects we tend to miss out. Even the so-called minor pharmacological properties of the ingested agents can produce a meaningful clinical challenges for the patient, actually. So I kind of want to emphasize the listeners that holistic toxicological vigilance is what something is needed because these things are often what overlooked.
I think that really highlights, and thank you for sharing
Yeah.
that. And I think it actually underscores how swift intervention and interdisciplinary coordination can turn around the case. What are the common pitfalls or delays you see in toxicology cases in the ICU, and how can clinicians be better prepared to avoid them?
See, the first common pitfall is one, there is a delay in recognition, delay in referral, delay in presentation. That is the most common delay. Because as we discussed earlier, the deliberate self-harm usually happens in a very discreet manner. So delay in picking up by the first responder itself will take some time. And the lack of use of toxin-based approach. So the key in toxicology is always the early diagnosis and management. Okay. For example, if there is a patient who presented with altered mental status, fever, delirium, hallucination, agitation, anhidrosis, dry mucous membrane, mydriasis. In case if someone is not having a bird's eye view on this, he may start treating a fever, this patient as a patient with meningitis, encephalitis, or septic encephalopathy. But if someone has a bird's eye view on all the constellation of symptoms, then he can understand that these are not an infectious manifestation. Probably we are dealing with the anticholinergic syndrome. So the first reason could be a delay in recognition and understanding of the toxin-based approach. Second thing is the delay in referral to the appropriate symptom. So one of the most critical pitfalls we frequently encounter in toxicological practice is the delay in referring the patient to appropriate center. Take for instance, if high dose beta blocker or calcium channel blocker poisoning, beyond a certain threshold, it becomes extremely challenging to manage the bradycardia and hypotension and life-threatening arrhythmia with conventional therapy alone. In such scenarios, early referral to a center with the capacity to have a transvenous pacing or ECMO is very crucial, and this can make a profound difference. These advanced modalities provide us with a real opportunity to stabilize the patient, the potential reversible condition. Third one is the over-reliance of the lab report. The first thing is the over-reliance of the urine tox screen, waiting for the serum paracetamol levels to start a N-acetylcysteine, waiting for the pseudocholinesterase for the management of OPC poisoning. So that is over-reliance of the lab report. Fourth one, overuse of the gastric decontamination measures. People often think that if a patient with some deliberate self-harm, accidental emission comes, they have to immediately decontaminate the stomach. It is not the case. American Toxicological Society have given stringent guidelines that gastric lavage has very specific set of indications. So you have to always mind the timeline and always mind the contraindication. So gastric lavage, the role is always less than 1 hour, and it has a specific set of contraindications. Activated charcoal, again, it is 1 hour, up to 4 hours in certain release preparations and certain other indications. So there is no role for induced emesis and catharsis. Fifth common pitfall is not calling for help. The help could be your paramedic, junior colleague, senior colleague. Not calling for cross consults, trying to manage some dialysable toxin by yourself with urine alkalization, forced diuresis, etc. And nowadays, there is an established National Poison Center, and there are some regional poison centers as well. For example, Christian Medical College Vellore offers a regional poison center. There is a toll-free number available in case if you are dealing with a poison, the management which you are not aware of, then you can call the regional poison center. Amrita Institute of Medical Sciences, Kerala also offers such a regional poison center. So the common pitfalls which I could immediately think of is one, there is a delay in recognition and lack of using this toxin-based approach. Two, delay in referral to the appropriate center, trying to manage the poison by yourself. And three, overuse of gastric contamination measures, overuse of this urine tox screen and over reliance on the lab. And five, not calling for help at the appropriate time.
Correct. I think preparation actually helps
Yeah.
even before the patient arrives. So it's really crucial. Now, finally, if there is one thing, doctor, that you would like every critical care professional to remember when dealing with a potential poisoning case, what would that be?
Okay. See, I can't say one thing.
Mm,
If you allow me, I can say. Uh, let me put up in this way. Okay.
sure, sure.
One, if you ask me what is the first thing,
Mm,
it is airway breathing circulation is a priority. Second thing, supportive management is a key. For example, the OPC poisoning per se may not kill the patient, but a hospital acquired infection may kill the patient. A good critical care, a good supportive management is the key.
mm,
Always remember the toxin based approach. And always remember toxicological causes in non-toxicology patient and non-toxicological causes etiology in toxicological patient. For example, cocaine intoxication is something which causes a lot of sympathetic surge.
mm,
So it can present as a young stroke. So patient will get referred to a neurology unit, may even get referred for a aortic dissection. There are case reports of patient getting operated for aortic dissection, but the etiology will be a cocaine intoxication. Paradoxically, altered mental status may be because of hypoglycemia, seizures, or CVA, not maybe because of your poison. So always remember toxicological causes for a non-toxicological etiology and vice versa also. Four, five. Qualitative tests may not add much of a value. For example, the urine tox screen. If patient gets intubated at your referral center using midazolam, your urine tox screen positive for benzodiazepine may not add much value. So don't give much emphasis on that. Time matters. Don't be in a hurry just because someone lands up in your ER for a deliberate cell phone. Don't be in a hurry to do a gastric decontamination measures. Avoid over reliance on the gastric decontamination measures. Treat the patient, not the poison. For example, if a patient who is a known case of seizure disorder comes with an overdose of lorazepam, is already intubated, there is no role for a reversal with flumazenil there. Because if you reverse that patient, then it can potentiate seizures. So, yes, the reversal agent for benzodiazepine toxicity is flumazenil. Theoretically, you are right, but you have to treat the patient, not the poison. Small investigation matters. ABG, ECG. For example, in tricyclic antidepressants, when to give bicap, your ECG tells you. In Clisandras cholinis, that is Uduantale poisoning, your ECG matters. It precedes your hypokalemia. And ABG, it can explain the HAGMA. Okay. In case of a female with childbearing age, you can always don't forget to ask the last menstrual period. With either patient's permission or a first degree relative's permission, get a urine pregnancy test. It's always important. And at last, it's a multidisciplinary work. Always handling a toxicology patient is a multidisciplinary work. It's not you, it's not me, it's us. It's a multidisciplinary work. So I can't remember one thing, but yeah. So
yeah, I think that's a great message to close with, Doctor. And thank you so much for such a practical and insightful conversation throughout, Doctor. And I think toxicology in ICU is such a high stakes and battlefield uh, approach. So thank you for sharing your experience, and it actually brings some clarity to the chaos. So thank you for sharing that. And to
sure.
all our listeners, thank you for tuning in to this episode of MedSynapse podcast series. And remember, if you're a healthcare professional who's eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource. It's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay aware and take care.